Hello, my name's Joel Dunning and we're here at STS 2024 in beautiful San Antonio with an absolute hero of mine, Raja Flores from the Mount Sinai Hospital. Always such a wonderful, eloquent speaker and no exception here at STS. And so I literally want to talk to you for 2 hours about everything because you always teach me so much. But one thing that you'll be doing very soon is you've got a little debate with Frank Detterbeck, and maybe you want to tell us a little bit about the topic and what you're going to be saying all about this subject.
So it's an interesting debate because it's very practical. You know, the Committee on Cancer, the Commission on Cancer in the United States, version 5.8, is recommending that every patient have 3 mediastinal nodes and 1 hilar node dissected. Every patient, without fail. And you know, whenever you're taking a multiple choice test, when they say always, that's probably not the answer. And so, you know, we're going to have a lively debate. And I'm excited. You know, Frank Detterbeck, when I was a resident in the 90s, I read all of his stuff. So he basically, a lot of his ideas I've internalized. So I couldn't be happier than to debate someone who I've looked up to for so long.
Yeah. So I guess the logic might be to try and encourage good lymphadenectomy, but I guess your point would be that this misses the point of being nuanced for the patient in front of you, would you say?
And that's the thing, it's very nuanced. You know, now in this age of personalized medicine, you need to tailor the treatment to the person that's in front of you. So just to say that every single lung cancer patient needs 3 mediastinal nodes and a hilar node at surgery, I can't swallow that. And especially nowadays, as our field has evolved, where we have gone from doing radical lobectomies, which is a lobectomy with nodal dissection, which originated at Memorial in 1960 by Dr. Kahan, now with Nasser Al-Turki's randomized trial, where wedge is okay. Things have shifted and we need to shift along with it. You know, nowadays we get so excited about immunotherapy, about targeted therapy, and we want to tailor that to the patient, if they have PD-L1 or if they have EGFR, etc. So I don't think lung cancer should be any different when we approach it from a surgical viewpoint, because nowadays, because of screening, we are seeing patients with part solid nodules, GGOs. We're seeing patients with cancers that just don't go to the lymph nodes. For more advanced, I'm all for it. Let's take out every single node and it belongs in the pot. But these early stage cancers, where should we even be operating on them or not, or should we just be observing them, to say to go in there and get lymph nodes from all over the chest, I don't know if that makes sense to me.
Yeah, and there's so many really important and relevant points. And maybe just the question about the CALBG trial, how has that changed your practice? Has that allowed you to feel that you can do a smaller procedure and go earlier in there? I often regard it sometimes with just going in there diagnostically to find out what is this GGO, and so how has that changed your practice?
It really hasn't, not because it's not an important study, but because we figured that out before the results. So we were already doing segmentectomies and wedge resections for specific types of lung cancers before the CALBG trial came out. So I think it's a very important trial, and I think it's going to help a lot of surgeons guide their practice, but we were already practicing like that before the results.
Yeah. So you're doing a talk about N2 nodes and N1 nodes. So the million-dollar question, you're doing a segmentectomy. What about those N1 nodes? Do you send them frozen? Do you worry about them? If they're positive, do you go back? What's your policy?
I mean, those are all good questions. It depends on what is the lesion that you're taking out. So let's say you are taking out a lesion, a solid lesion. You're doing a segmentectomy and you take out that node and you send it for frozen and it comes back as positive. Do you complete the lobectomy? Is that enough? And there's going to be some other abstracts at that setting that talk about that. And I think we still need more data to determine it. When you look at the JCOG trial, the Japanese trial that showed segmentectomy versus lobectomy, they went ahead and did the lobectomy when they had positive interlobar lymph nodes. That is our philosophy now, but with time and more data, will we say, okay, segmentectomy is okay, even if the nodes are positive, as long as you get rid of all of them? Will that actually change survival? I'm trying to put myself on the table. If I had a segmentectomy and those nodes are positive, would I be happy not having a lobectomy? And I think I'd want the lobectomy. But that's my bias, and I think a lot of the data is going against that. I think a lot of the data is showing you don't need to complete the lobectomy, but it's very hard to change what you've been raised with.
Absolutely. And I guess in America, if we go to the much more severe end, the N2 or even N3 patients, there's so much chemo-IO and neoadjuvant treatments. And how has your practice changed in the last sort of 3 years with this avalanche? And how do you keep your head around it all?
It is tough to really get your arms around all the new data coming out. And I think as surgeons, we have to be very skeptical about what we're reading. Almost every single trial, induction trial that you see, they say there's no difference in surgical resection between the two arms, meaning you have the neoadjuvant arm with induction immunotherapy and the chemo arm with induction chemo. No difference between the two arms. But induction chemo is not the standard. And when you look at both arms, sure, they equally go to surgery, but when you look in the supplements section of these papers, you'll note from study to study to study, Agent, Checkmate, Heather Wakely's study, all these studies, 20% in both arms don't make it to surgery, and another 20% have delayed surgery. So 40% have their surgery affected by the neoadjuvant component. So I'm not jumping on that bandwagon as quickly as I think everybody else is. And we recently have new data coming out of our institution that when you delay surgery by 2 to 3 months, depending on the type of tumor, you have fast-growing, medium-growing, and slow-growing. With a fast-growing tumor, if you delay that surgery by 2-3 months, you can potentially affect 5-year survival by as much as 8%. So we need to make sure that if we're given induction chemo, that the benefit we are getting of that induction chemo outweighs the potential downside of delaying or not even going to surgery. And I just don't see anyone bringing up that conversation. Many times we take these randomized controlled trials and say, okay, that's it, this is law. And I disagree. I think actually for surgical practices, I have a master's in biostatistics and clinical research methods, all that stuff. I just don't know if I buy that randomized controlled trials are going to answer the question for many of the things that we practice on today. And like ACOSOG Z30, randomized controlled trial, no difference between nodes and sampling. We kind of knew that. Nasser's trial, lobectomy versus sublobar resection. We kind of knew that. Mars, I don't know if we're going to be able to answer the meso question with the randomized controlled trial. There are other ways to do this, and we don't always need a randomized controlled trial to make common sense out of things. Now, I'll tell you, there's a Yankee, Yogi Berra, who said common sense ain't too common. So I do think we need these studies to go ahead and answer these questions, but in general, most of it, I think we can figure out.
Yeah, I mean, to your point, a lot of these are drug company sponsored trials.
Exactly.
And they take a huge wild group of patients, and perhaps the 3ANs and the 3BNs are dragging the differences, whereas your stage 2 person who are bigger than 4 centimeters, stage 1 patient, maybe they don't need this treatment.
I agree. I think there's a lot of questions, but these randomized trials that we're embarking on aren't necessarily answering them, and they're actually generating more questions than answers. So I am curious to see in which direction the field goes, but I'm concerned that many people are jumping on this bandwagon without enough evidence to support it.
I guess at the STS just now, we just heard the President's speech talking about the amazing STS database, linking it to long-term survival and readmissions in hospital. Do you think instead of these randomized trials, we should maybe be looking to huge database studies, or do you think they can't keep up with the changes in neoadjuvant treatment?
Well, I think it's very important to understand, just like everyone knows, garbage in means garbage out. So your data is only as good as the quality of the data that you record. At our institution now, we have something called ILCART, which is the International Lung Cancer Action Project treatment. So ILCAP is the group that knew ahead of time that lung cancer screening worked. The NLST trial was put together to prove ILCAP wrong. So, of course, I'm biased. This is at our institution at Mount Sinai in New York City, Claudia Henschke, David Yankelevich. So, in 2006, they came up with their study that was published in the New England Journal of Medicine that said screening works, CT screening. And then ILCAP came out in 2011. It was supposed to say that it didn't work, but it did the opposite, and it showed it did work. So we took that methodology and we created something called IL-CART, which we are looking at surgical questions on the same methodology that figured out that lung cancer screening worked without having to do a randomized controlled trial. And so all of that is in place at our institution, and I just think that may be a better way than these expensive randomized trials. And then the data is obsolete. With this, it's a continuous prospective gathering of data with specific questions in mind at the beginning. So over the next 20 years, we know what we want to look at. And so as things advance, PET scan, newer techniques, that's incorporated. So, you know, with some of these randomized trials, let's say ACOSOC Z30, there's no PET scan, you know, so you need to be able to look at these trials as they are developing.
Yeah, that's a really fascinating approach. And I guess mentioned very briefly was the Mars-2 trial. Again, another example of a randomized trial. And you're obviously an absolute expert in mesothelioma surgery. You know, how has that impacted your practice? What were the weaknesses of that? And could this new methodology you discuss, you know, could that be a better solution for the mesothelioma where we go next?
I think mesothelioma is a very difficult disease to get your arms around. Is it a surgical disease? Is it not a surgical disease? It's been a surgical disease since the 1930s. Have we been wrong all this time? I don't know. Of course I'm biased. I operate on mesothelioma. And it's funny because some people were saying, well, you're going against going after lymph nodes, but you operate on mesothelioma. Yes, there is contradiction in everything we do. And I think that with specifically the Mars-2 trial, there were just so many flaws. The operative mortality approaching 9%, 15% had non-epithelioid tumors. They'd operated on 4% who had M1 disease. There were just many different flaws. And when I looked at the statistics of the study, it looked like they were doing statistical gymnastics. You know, there's a saying that when the study works, you have your p-value of, you know, less than 0.05, et cetera. When that p-value starts going higher and higher, look at this great subset analysis, you know, so I think I think it was a valiant effort. I think we need more surgeons involved in clinical trials, but we also need to make sure that it is reflective of real life. And I don't think the Mars trial in its haste for completion is how we actually practice on meso patients. So I don't agree with their conclusions.
And where do you think the future lies in mesothelioma surgery? Would you say it is in the database that you describe, or where are we going, would you say?
Yeah, I think you need something like what we have, IL-CART, where we're trying to figure out these answers using very specific prospective data that's gathered by our researchers. But meso is, you can do a lobectomy. That's on you, on me, that's a lobectomy. When you have meso, you know, it has a propensity to spread through the tissues and planes. No two mesos are the same, so it's very hard to have a control group and an experimental group. And a lot of it, and just like much of what we do in surgery, is based on the patient in front of you and based on your own biases. So I'm biased as a mesosurgeon. I think mesosurgery works, and I think it's something that really adds life years to the patient. But I know some medical oncologists don't buy it at all. They're like, no, you're gonna live or die as long as you're gonna live or die with or without surgery. I understand where they're coming from. I've had some meso patients who refuse surgery, who I just drained their effusion, and they're alive 7-8 years later. But I also do have patients where I've done pleurectomy, decortications, even extrapleural pneumonectomies, and they're alive 15-20 years later. Are they alive because of what I did or in spite of what I did? I don't know. But, you know, as a surgeon, when you're a hammer, the whole world's a nail, so you operate.
Yeah, absolutely fantastic. And so where do you think, perhaps in the lung cancer surgery, where are we going in the next 5 years? To me, it seems an inexorable track into neoadjuvant treatments and then post-surgery treatments. But if we're talking in 2028, in the STS in Mount Sinai, maybe, we can come to you. What do you think we'll be talking about?
Well, I think in cancer surgery in general, we're moving towards less surgery, not more. When you look at the radical mastectomy, right, you go now to lumpectomy and radiation. When you talk about, colon resection, where we would, or stomach resection with the D2 nodal dissection, I think we're going to less surgery, not more. We went from pneumonectomy for lung cancer to lobectomy to now less than a lobectomy, wedge resection, segmentectomy. Same thing with mesothelioma. We went from extrapleural pneumonectomy to pleurectomy decortication. So in every area of cancer, we are doing less and less surgery. And that's why I think this nodal discussion that we're going to have is an important one, because it's, do we do more nodes or do we do less nodes? And it depends on the tumor. I mean, when I have more advanced cancers, I will take every single node that's in that area, but do we need to do that for these little guys? I don't know. So I think thoracic surgery, along with cancer surgery, is evolving to the point of being smaller, less invasive, better operative outcomes. When you look at the CALGB trial, the mortality rate was extremely low. It was less than 1% in each arm. So as we have advanced in time, our mortality rates for the surgeries we do are getting lower and lower.
Yeah, and it's really important, because that means we can do older and frailer patients, isn't it, at the end of the day? And I think that's super important,
and
because so many people don't get treatment, or the adequate treatment they should have, because they're 85 or something.
No, I completely agree. You have to look at that individual. I just did an 83-year-old with an esophagectomy, so I think that as we move forward, we just have to be sure that just one size doesn't fit all.
Yeah. Well, I'll be voting for you on your side, so best of luck with that. It's such a pleasure to talk to you as always, and it's really great to see you. Thank you so much for coming to talk to us here at CTS.
No, great to see you, Joel. I'm glad you're heading CTSNet. I couldn't think of a better person.
Oh, you're so kind. Well, thanks a lot, and hopefully we'll talk again very soon.